Just as background, you know, if you look at our protocol and our clinical standards, we have focused quite a bit recently on termination in the field. So you know, the focus is to identify those patients who are not suitable for ongoing resuscitation and to terminate in the field rather than transport emergently to the hospital where they're going to terminate. Over the past years, we've had conversations about what resources do we have as providers in the field to help the family with termination. And we really have come up pretty empty. So we talked at one point about is there any faith-based organization out there that may represent all of the faiths but would be available to come and help us with family members? There really isn't. Some of our departments have a chaplain who will help if available. But a lot of what we've looked at really wasn't available. If you look at what we do as part of our clinical standard, the battalion chief or the officer on scene is responsible for interfacing with the family. We want the medic crew to deal with the patient. We want somebody to deal with the family. And as part of that interaction with the family, we would like that officer to keep the family appraised of what's going on and to prepare the family if there's that eventual outcome that we're going to need to terminate in the field. We also have an interest in terms of providing resources to our providers so that if you terminate in the field, we can do a little bit more than say, sorry, your loved one has died, and then leave them with a law enforcement officer who may or may not be really capable of dealing with the family. Or they just don't have the resources either. So one of our goals is to identify resources that would be available for you as providers in the field to help the family. Now, we're not talking about spending 2 hours with the family like our chaplains may do at the hospital. It's more that 5, 10, whatever minute is necessary interaction, and leave the patient with resources so they have somewhere to start. Also along the way, Chiefs Rupp and Chief Ken Taylor identified Tim Dietz as a speaker who has a special focus on grief and termination in the field and how we interact with the family. They identified the text, which we've given out as kind of a reading assignment, and hopefully you've read it. So look at that. Please read it. It's got a lot of helpful hints, and a lot of what we're going to talk about today is based in part on his book. As we developed this, we realized that we all, have patients who have different preferences in terms of their religion. They have different preferences regarding their healthcare providers. So we brought in Mount Carmel Health and Ohio Health and Loop to start talking about what resources they might have available that we could use to share with our patients. So we've kind of taken a non-denominational approach to this from the perspective of religion and affiliation with healthcare providers. So thanks to those folks from those organizations, because they do this all the time, and as one of the folks from Mount Carmel said, we have a hospice organization, and what you're looking for, we have to have in order to be certified as a hospice. So a lot of that falls into this, and that's why we have resources here. As one of the materials that you hopefully picked up was a course evaluation. I hate these things. I mean, when I go to a course, I click the yes or no or 0 to 5, but ask me for the written comments. I generally don't. Well, I need your written comments because we really want to make this better. We think it truly represents material that all of us should have as a resource. So please, good comments, bad comments, let me know what you think. Eric Taft's in the back. He's recording this, and we hope to edit this and post on Workplace, so that as company officers, if you want to sit down with your crew and take snippets of what we've talked about and have them sit through it, we'll do that. We'll set it up so in Vizia, just like we do with Mech Minute, so that you can answer questions along the way and get some credits out of it. So that'll hopefully be posted. Probably take us a couple weeks to get it done, but that'll also be available for training with your crews. And you can pick and choose. It'll probably be at least 4 different segments. You pick whichever one you think is best. So you can leave mine out. You can use Gunners and Liza's and so on. So just thanks to those who are involved. We're going to talk a little bit about what is the medical perspective, and let's start with a scenario. So you're on duty and your crew's called out on a 78-year-old female in cardiac arrest. The arrest is witnessed by a spouse who attempts compression-only CPR. dispatcher was on it that day. CPR was continued by the first in-engine company. ALS and battalion chief arrived shortly after the engine, and resuscitation is continued for 25 minutes to no avail. Crew terminates resuscitation. What are we going to do next? So that's what we're going to spend the next hour and a half talking about. Why are we holding this class? Well, you know, our clinical standard focuses on or allows termination in the field. I can guarantee you, you know, if you want to know how I think, read the MEC minutes, because that tells you where I'm going to be in 6 months. But one of our focuses has been and will continue to be stopping resuscitation in the field for those patients who are not responding. You train more than we train at the hospital in terms of cardiac resuscitation. You have the same equipment, if not better equipment than we have in the hospital, at least newer equipment than we might have in the hospital. So the likelihood that you are able to, or that we in the hospital are going to be able to get somebody back that you don't get back is pretty low. If you look at the data out there, if you're an ALS or a systolic or PA arrest, the likelihood of survival after 25 minutes of resuscitative efforts is less than 1%. If you're looking at VFib arrest, it's at 43 to 45 minutes. Your likelihood of survival is less than 1%. So if you have a PEA arrest, asystolic arrest, and you've already worked them for 20 to 25 minutes and nothing has changed, the likelihood that I'm going to get it back at the hospital is less than 1%. Cardiac arrest in the field are usually unanticipated by the patient and family. Therefore, the family and the friends are not prepared for the patient's death. So how many of your patients, outside of hospice patients, is the family prepared to deal with the patient's death? There are a few resources immediately available on scene to provide emotional or spiritual assistance to the family. I think you know that better than I do. Family and friends don't know what to do or expect over the following days. I have good resources at the hospital. Every time I have an unexpected death, one of the first things I hear from the loved ones is, I don't know what I'm going to do. I'm sure you hear that too. Our goal is to at least give them some guidance. But ultimately, and Tim Dietz makes this point, how you interface with the family, how I interface with the family, it has a lot to do with determining how that family or how that loved one recovers after the death of the patient. So if we're cold, callous, and don't show much empathy, if we say the wrong things, that's going to haunt the patient, or I'm sorry, the family members, the loved ones, for a much longer period of time than if we have an appropriate interaction with the patient, I'm sorry, I keep saying the patient, with the family and the loved ones. Anybody disagree with that? So this is really why we're here. Just a couple of things that I've heard over the years, just some points of clarification. Durable healthcare power of attorney. This is a legal document. It's available online. The state has a boilerplate form. You can fill in the blanks. And it names an individual that's empowered to make healthcare decisions on behalf of the patient, the person who signs the form. The identified individual can make healthcare decisions consistent with the wishes of the patient, but the designated power of attorney cannot overrule a living will. So a living will is a legal document that supersedes anything else. And it only covers healthcare issues. So in terms of healthcare durable power of attorney, it can only have to do with issues related to healthcare. It doesn't have anything to do with who can handle the bank account and so on. So that's a different document. There's a living will, which identifies the patient's directions regarding use or non-use of artificial life support, should the patient not be able to make decisions on their own. It's only effective if the patient can't communicate their wishes. So if the patient is comatose, if the patient is demented, and so on, then the living will is in effect. The living will by itself cannot really allow you as a crew to make determination of withholding resuscitation. Now, you can have a designated power of attorney on scene who says, on power of attorney, they do not want to be resuscitated. They can speak on behalf of the patient, and you don't resuscitate the patient.
Provide that to us?
Yes, you need to see it. And then the hierarchy of patients' agents. So suppose you get on scene, there is no living will, there is no other material available. Can anybody speak on behalf of the patient? Well, yeah, there is something you can fall back on. So the patient's spouse is the first in line to speak on behalf of the patient. The next in line would, the legal guardian, which is usually the spouse, and then the patient's spouse, adult children, then parents, surviving parents, and then finally adult siblings. So if you're ever on scene, who can speak on behalf of the patient, this is what is recognized as the hierarchy, at least in the state of Ohio. DNRs, I think everybody knows about DNR-CCs and DNR-CC arrest. We have to have it documented. I run reports on a regular basis where the patient's supposed to be DNR, but there's no paperwork available. Be aware that there are armbands that can be worn by patients. I haven't seen one on a patient in a while that says that the patient is a DNR-CC or DNR-CCA. And you have to be able to see it. And the last thing is, if the DNR form is signed by the patient and appropriately countersigned by a physician, nobody can revoke that except the patient. So if the patient was at one point competent, signs a DNR form, is now no longer able to speak on their own behalf, but they signed the form, nobody can revoke it. So the power of attorney cannot revoke a DNR form signed by the patient. The patient can at any time. Role of the battalion chief, let's substitute company officer, let's substitute officer in charge based on what resources you have available. For us, logistics and scene safety always comes first. What resources do you need? Call for more help if you need it. If you're first on scene, you get to do CPR and AED. I remember a patient a couple years ago where Madison's battalion, first on scene, put the AED on, defibrillated the patient. The patient was awake and talking before the medic got there. It was a great case. Doesn't happen very often. Most chiefs slow down until the medic gets there first, right? You interface with the family, and that's an important part of what we're going to talk about. So a lot has to do with demeanor. Introduce yourself and shake hands. Okay, I'm Chief so-and-so. Identify that you are the patient's contact. I'm here to help you. I'm here to serve as the, keep you appraised of what's going on with the crew. Come up with your own lingo. What works for you? It has to seem natural. It should be natural. Is there a comfortable place for us to gather the family? So, I've been with you where, the patient's on the kitchen floor, the family starts to cluster, and somebody starts moving them out of the way so the crew can do what they do. So we're looking toward the battalion or the officer to help keep the family appraised, but also keep them out of the way so the crew can do what they need to do. And what's happening? So, or what happened? How did you find the patient? Did you hear him go down? Did you see him go down? Did anybody do CPR? What can you tell me about the patient? Okay. Does the patient have a DNR form? Does the patient want us to resuscitate them? That may be particularly important if you're looking at a frail 80-year-old lying on the kitchen floor versus a 40-year-old lying on the kitchen floor. Has the patient ever discussed their wishes? It's amazing how many times I get to be their first provider in the patient's contact who discusses things like code status. The patient's got chronic illness, sees 3 physicians, nobody has broached the subject of what is the patient's resuscitation status, or what do you want us to do if you stop breathing. Family interface, it's not the family's fault. And I think that sense of guilt is something we have to allay as soon as possible, because the vast majority of the time, what's happened to the patient is not the family's fault, but they start to feel guilty. 2 minutes? Oh, I better start moving faster. When we arrived, we found Mary unresponsive, or let them know what's going on. When we arrived, Mary was unresponsive, not breathing. We couldn't find a pulse. We started CPR. Did Mary ever discuss what she would want to be done if this happened to her? In layman terms, explain CPR, talk about what we're doing, the IV, the IO, intubation, whatever. Let them know the crew's working hard. And they're well trained to do this. We train on this a lot. Mary's getting the same care that she's going to get in the emergency department. My partners will shoot me, but I would advocate that she's probably getting better care. Okay? The resident's not practicing intubations on this patient. You guys practice compressions and airway adjuncts much more than we do in the emergency department. Leave and return to family. Be the yo-yo, back and forth. You're the communicator. EMS crew, what is progress? Shortfalls to response to treatment. We're working on her. She's not getting better, or she's getting better. We had a shocker, and her heart came back, or her heart didn't come back. We want to tell the family what the progress is. With the crew, you want to keep up to date, and you also want to let them know what you found out. She's got history of coronary artery disease. She's got AICD in place, which they can probably feel. And then start introducing the idea that if Mary fails to respond, we may need to discontinue our resuscitative efforts. Family notification, make sure everybody's in the room, make sure everybody's present. Update on Mary's failure to respond. We have worked hard to revive her. We've had a couple of families over the years who've complained because the crew doesn't seem to be agitated enough during the resuscitation. Well, maybe it's time to introduce, the crew as professionals. We're professionals. We practice all the time. We train all the time. Because we're not excited, it doesn't mean we're not concerned. Matter of fact, if we start getting excited, we've probably lost control. Further treatment is futile, and we need to stop. Would you like to be with Mary when we stop? That last contact with the loved one is important to the family members. So, you may not be able to get all 20 in the room, but maybe 1 or 2 representatives. Mary is dead or died. We use words dead, died, passed. Where did they pass to? So we'll talk about that. No jokes or high fives. We all have our humor, and that's the whole way we survive sometimes is with our humor, but others don't understand our humor because they don't do what we do. So we all have to sometimes bite our tongues, but be careful what you say. There are a couple of times, and it still happens to me after 30 years, I kind of joke about something, and then I realize that I probably should have waited till I got back to the nursing station. So be aware of that. And clean up. Don't leave a mess. Bad news in small doses. Mary's got no pulse. We'll have to shock her heart. The shock didn't work. We had to put a tube in her throat. We've been doing this for 20 minutes. We need to start thinking about stopping. She's not responding. We have tried everything without success. We're going to stop now. Would you like to be here or be with her when you do? Mary has died, or Mary is dead. Would you like some time with her? We can afford to give the family a couple of minutes with the patient, most of the cases, unless it's a crime scene. Do they want a couple of minutes? Do they want to touch? Tips: be truthful, give the dose or the message in small doses. Allow others to spend time with their loved one if you can. Show that you care. Allow family members to grieve, and people grieve differently. We've all seen that. Different ethnicities grieve in different ways. Certain behaviors are not allowed, like throwing furniture, but people grieve in different ways. Offer continued support and cover the body. This is by Hobgood. It's in the packet. It's a resource. It's just a way of talking about grief. I can tell you I've been doing this for more than 30 years. Nobody's ever told me how I should interface well with the patient. But remarkably, over the past 30 years, I've adapted a lot of the practices which are recommended by Dietz and others, but it's by trial and error. It's not because a chaplain or anybody ever sat down with me as a physician and said, here's how you best interface with family members. Go back.
For the bottom one about organ donation, how if we stop in the field and they say, we're doing organ donation.
We got to talk on that. So we'll have a talk on organ donation because that frequently comes up, and Ann is going to talk about that toward the end. Post-notification resources, law enforcement and coordination. Ask about clergy. Is there a clergy member, or do you belong to a particular church that we might contact? Do you have friends that we can call? We can talk some about what happens next, and that's some of the resources we want to give you, and leave the patient with law enforcement. So we have some resources. We have some resources from Mount Carmel and from Ohio Health. We have a list of funeral homes, which we think is complete for Fairfield, Licking, and Franklin counties. And we have some resource information in terms of grief resources that are available in the 3 counties. So you'll hear more about that from the experts in a couple of minutes. Answer questions honestly. Was he or she in pain? Can the organs be donated? Again, you'll hear about that. And what am I going to do?